Alright, really quick. That's the topic. Defense mechanism and dementia Alzheimer's. So this is an example of defense mechanism. They're going to be asking you on how to identify different defense mechanisms. Okay, so here's an example. The nurse is assisting with a court-ordered admission of a client to a substance abuse program. The client states, "You are all," there's a hint here, "you are all angry at me and wish you could go out and have a drink." The client's response is an example of which of the following defense mechanism? Projection. Very good. The other one that's going to be on your exit is reaction formation. When you say reaction formation, you're actually showing the opposite emotion. So let's say, for example, you are being kind to someone you like. Yeah, I mean, you don't like. Let's say you hate that person. What you do is you're being kind to them. Be kind. So the other one is, let's say you have a crush on someone. Instead of showing them that you love them, you actually tease them. You take tricks. So it's showing the opposite of your emotion. That's reaction. So don't forget that. When you show the opposite of how you really feel about that person, that's reaction formation. Is that clear, guys?
Yes.
Alright, very good. The next one. A nurse is assessing a young adult client who has a new diagnosis of IJA, or idiopathic juvenile arthritis. The client states, "The pain in my joints is just a temporary thing. If I keep eating right and exercising, it will go away." The nurse identifies that the client is using which of the following defense mechanisms. So clue here, IJA is not a temporary thing. It's actually a chronic, long-term problem.
Denial.
So what do you think is the answer?
Denial.
It's denial. That's right. You know, you have a terminal illness, you have a serious illness, you decide to go to, like, Hawaii or Aulani and, not to think about seeking help or medical attention. That's denial. So it is. That's what a denial is. You're not facing the truth that you have something serious. Okay? That's denial. Alright, the last one. A nurse is assessing a client in an emergency department who drank alcohol while taking the Soparan. That's a good idea. Right? It makes them sick. The client states, "The nurse told me not to drink when taking the medication. I am just a social drinker. I didn't realize that having just one drink with my friends would cause such a problem." Which of the following defense mechanisms?
Rationalization.
Rationalization. There it is. Rationalizing your action. No, I didn't know. It was her fault. Because of you. Rationalization. So please don't forget those examples, okay? So reaction formation, denial, and then you have this
projection,
rationalization. And then the other one that I mentioned about regression. Okay, so don't forget this, because this will come out also. Remember regression? You go back to a younger age. My example was, you have a 10-year-old potty trained, they get sick, they started urinating and having bowel movement back in there, right? That's regression. Alright, here we go. Last one, guys. Dementia, Alzheimer's. Alright, so here we go. The focus on dementia, Alzheimer's is not really the treatment, but more of how do you handle the manifestation of the condition. So, here are some. This is just what you have to remember, okay? I've already put it here in the list.
Put it.
One thing that they'll ask you on manifestation, wandering. Okay, what does wandering mean? You walk around, sundown. That's a expected characteristics of someone who has Alzheimer's. They wander. Okay? Now, when they wander, here's the thing that you have to do. Provide a safe environment. Make sure that the surroundings are clear. You don't have certain, obstacles or objects that can trip or cause injury. One example is a rug. When you're caring for a dementia Alzheimer's patient, should you have rugs on the floor?
No.
Another example is electrical cords. So should you have electrical cords on the floor? No. It should be tucked in, a furniture or towards the wall so that no one would actually trip on it. How about if you cover the cord with a rug?
No, not a rug.
No, that's not safe?
No.
Right. That's double jeopardy. Cover the cord with a rug, that's big problem. You got two that can cause injury there. Okay? Lock windows, lock doors. Another thing that's important, if the facility or the house has a stair, you want to make sure you mark each step. Okay? Each step
Steps
has to
on
be marked.
stairs.
Right? What is that for?
They know the end of
They
the
can
stairs.
see it,
Yeah.
prevent them from falling, right? So they can see each step. The edge of the step. Yeah, mark it with something like, bright color or neon so they can see each step. Right? So they don't trip. They don't fall in that area. Again, lock windows, lock doors, and if they're in the facility, use identification bracelet. Okay, next one, impaired communication. Before we go to talking, first is hearing. A lot of your dementia, Alzheimer's patient also ends up being hard of hearing. Take note, very important note. Let's say, for example, let's say I am the nurse. Here's my dementia patient. Okay? Make sure that you're in a well-lighted room. Okay? And make sure that, here's the thing, the description, the light should be behind the patient, not in front of the patient. Okay, why? Because if the light is behind me, then the patient can see the light, they won't be able to see my lips. The clue there, the actual important thing there is for the patient to see your lips. Why? They can actually understand you better even if they can't hear you by just the movement of your lips. So again, where should the light be? Behind me or behind the patient?
Behind the patient.
Behind the patient. Because when the light is behind the patient, it will be on the nurse's face, and the patient can really see your lips. Is that clear? So, the next thing, use simple sentences. Make it simple. Do not use nursing or medical terms. If they don't hear you the first time and you need to repeat it, you have to say it exactly the same way. Don't rephrase. Okay. The other thing, Alzheimer's patient eventually is not gonna be able to read. They lose that first, their ability to read. But they actually understand
Pictures.
Okay? So make sure
Use
that your
pictures.
signs are made out of what?
Yeah.
Pictures. Large signs with pictures, because they can understand that better. They lose the ability to recognize shapes and pictures later. But the ability to read, they can lose that, earlier. Okay, so make sure they're using what?
Pictures.
Okay? Right? Alright, the other thing, if you are to make brochures, make sure that your brochures are written in 8th grade language. Okay? 8th grade.
Hindi ko naman siya.
Has to be 8th grade.
Yes.
Okay, why?
I know secret.
Because the reading comprehension as average in the United States is at the level of 8th grade. So make sure that
You
are
had that right.
using 8th grade type of sentences. okay, and works, 8th grade, okay? Alright, the next one. Judgment. So they have 4 judgments. So again, safety is a big issue here. The water heater should not be higher than 120 degrees. Okay, that would be too much. So you want it below 120 degrees. So that's the max, 120. Like medication, toxic chemicals. If there is an option A, out of reach, and then B, locked, which one would be the best answer?
Locked.
Locked. The best answer is locked. Because even though if it's out of reach but it's not locked, they might find a way to actually get to it. So what's the best way?
Lock it.
That's the best answer. Good. Alright. And then of course, electrical appliances, you already told you the ports, make sure that they are hidden. Alright, next. Afterthought process. Make sure that you're actually calling them through their own name. First name, last name. You know, sometimes in nursing, they use sweetie, honey, grandpa, or grandma. Basically, they're not really your grandma and grandpa, right? What is that gonna do? It's gonna confuse them. Right? It's gonna confuse them. Okay. So, use their real name. Okay, use their real name. Also, clocks, calendar, big numbers. Okay, big numbers so that they can actually what? See it. Big numbers so that they can actually
calendar.
The other thing, objects, personal objects should
Within
be
reach.
within
Reach.
the area where they walk around. Why? That helps them reminisce. So, this is the one thing I'm going to tell you. There's a clue. You see on one of the options says reminisce, pick that answer. That's the best one. Okay, so when you say reminisce, what is that? What's reminisce? What's this?
God, I cannot spell.
Remembering the past. Right? Remembering the
Reminisce. There you go.
So reminisce. Allow them to reminisce. Allow them to remember the past. Okay. Next one, very important to know. Activities. They're going to be asking you, what is an appropriate activity for dementia Alzheimer's patient? Here's the clue. Make sure that it is not brain tasking. Okay, so let me give you an example. Chess game. Would you pick that?
No.
Sudoku.
No.
Concert at the park.
Yes. What do you mean? Yeah. You're just.
Park they can wander, and the concert is what?
No. Oh, yeah, that's right.
Too much moves. Okay, how about coffee social?
Yes.
Yes. Okay. Coloring books.
Yes.
Okay, so walk in the patio, walk in the garden, coffee social, ice cream social, coloring books. That's what you
Shoot, I want that now.
can do. Pencil?
Puzzles.
Two brain tasking. Why? Unless the puzzle says 5 P's. The reason for the puzzle is it will make them think harder. The more they think, the more it uses the brain. So it actually makes the Alzheimer's dementia faster. Remember, Alzheimer's dementia, there's no cure. It progresses. You want the key to an Alzheimer's dementia is slowing down the progression. So that even though your patient is already old, they don't get the severe form of Alzheimer's. You know, like especially like the one right now, the actor, Bruce Willis.
Oh, yeah. He was in Die Hard.
Yeah, his Alzheimer's though is very progressive. It is deteriorating really fast. But you see the thing there is you want to slow down that progression. Alright, next, after sleep. So they wake up. This is not something that is abnormal. They do wake up sometimes in the Take note though, please make sure do not pick an answer to take them back to their room to sleep. They won't do that. What's the best answer? Allow them to walk around. Just monitor them to make sure that they're not going into other patients. And eventually, they get tired, they will go back to sleep. But don't force them. Okay? They're not gonna understand that. Remember, they have Alzheimer's dementia. And then for agitation, okay, make sure that for agitation, separate them immediately from the group. Okay, there's a question on our exit that you have an Alzheimer's dementia patient who starts screaming in the activity room. They start screaming in the activity room. Do not take an answer to talk to that patient in the activity room. Okay, why? They won't listen. And if there are other Alzheimer's dementia patients in that room, what's going to happen?
They'll trigger them.
All going to start screaming. Right? So what happens? It's out of control. You guys screaming party. That's going to happen, right? So what they do? Separate them from the group. Talk to them in a separate room or space. Okay, is that clear, guys?
Mm-hmm.
All right, very good. Last one. Okay, last one. There's a situation where an Alzheimer's patient might sometimes see things. They do have some episodes of hallucination, although not as severe as psychosis. Okay? Very important to know. Number one, don't pick an answer to give them anti-anxiety meds. That's the worst thing you can do. Why? Anti-anxiety meds makes them more confused. So don't pick that answer. Okay? The other one, don't pick an answer explaining that it's not there. Because just like someone who has schizophrenia, they know that it's what? That it's there. Okay, they won't believe you. Right? So what do? Allow them space. Take them where? To another environment or another part of the facility. Because what? That's Alzheimer's dementia. Eventually what they will forget about it. They will forget about it. So what do? Take them to a place where they can move around. Is that clear?
Yes.
There you go, guys.
Yay!
Disorders. Really quick, just want to make sure everyone's aware of this. On the immunization for newborns and toddlers, one very special one is the rotavirus. Don't forget that. Because rotavirus is actually given in what route?
Oral? Okay, coronavirus.
Please do not forget that, because that's something that is not administered via bacillus lateralis. Okay? That is given oral. Okay? It's an immunization. Rotavirus. Rota. R-O-T-A-V-I-R-U-S. Rotavirus. Alright, so let's start. There's only a few disorders anyway that's on maternal. We already discussed one of it, which is postpartum hemorrhaging and what are the things to do for postpartum hemorrhaging. And then on the Peds, there's also very little. We did discuss already the use of talent harness for hip dysplasia. And then I'll just go really quick on those two. But let's start with this. So maternal or gestational hypertension. The other name is preeclampsia. So maternal hypertension is something that happens to the mom, of course, because of pregnancy, which means that to begin with, the mother is not hypertensive and only developed the problem of hypertension during pregnancy. Okay, now, very important, two of the classic signs that they'll ask you, especially on our MGN, is the edema, especially the edema of the what?
Ankles?
Foot, right? Primarily the lower extremity, wherein you have actual pitting edema. Okay? And of course, the presence of protein in the urine or in medical term, it's called proteinuria.
Proteinuria.
Very good. Okay, so the presence of protein in the urine signifies that the condition is actually worse, and it's resulting now to what? Kidney damage. Protein is too big to leak out, okay, of someone's kidneys or glomerulus. One of the reasons it would leak out is because of damage already to the kidneys, which tells you that their blood pressure is probably what? Too high. Okay, so other than the edema, other than the proteinuria, of course, elevated blood pressure is one of those classic signs. Now, yes.
If the people are swollen, we should put the people on bed rest or do you put them on
It's better not to stop.
Yeah.
But here's the thing though, also, you want to make sure you also monitor the salt level because pregnant women have a tendency to become hypernatremic, which also results into fluid retention, causing hypertension. Okay. And of course, elevation. That helps. Okay. So what is the answer of the one that you actually put in bed rest? DVT. Right? Someone who has DVT is not supposed to be ambulate. Okay, because why? Ambulation causes the DVT to what? To dislodge. Now, if the question is how do you prevent DVT, what would be your answer? Ambulation. There's two different things about preventing it and when they already have it. Right? When they already have it, they're supposed to be bed rest to treat the DVT. But if they don't have it still, how do you prevent it? Ambulation with motion. Right? Those are the things that we do. So that's where bed rest actually comes in. Alright, now, if the woman though develops damage to the kidneys as the result of preeclampsia, that also requires bed rest. Because why? You need time for the woman to actually develop the kidney to heal, but only in the situation that the woman presents with kidney damage. So other than proteinuria, because again, this is on our exit, what did I say yesterday is a classic sign of kidney damage?
Allegoria?
Decrease in urine output. Think of it. If they have a decrease in urine output, what is something that you will see that gets worse? Their
creatinine?
edema.
Okay.
Resulting into knowing that the preeclampsia is actually getting worse. Preeclampsia gets worse, kidney gets damaged, what happens? Urine output decreases, what gets worse? The edema. Because now they're retaining a lot of fluid, which will also result into higher blood pressure. It's a vicious cycle, guys. That's how it works. Vicious cycle. Once something gets up, result into preeclampsia. So a variety of factors can predispose the woman to this. Okay? And one of the leading factors, remember yesterday, is weight gain. We don't want the woman to gain more than 35 pounds, right, during pregnancy. So what are the things to do? It is. It's the plan. I'll ask you this in our MGN. Okay? Maintain bed rest. Place the client in a left side lateral position, especially because of possible what? Kidney damage. Monitor the blood pressure and weight the client and inspect the client for signs of edema. Monitor the intake and output. So if you're monitoring the intake and output, are we encouraging this woman to drink more fluids or are we restricting the fluids?
Restricting.
We are what? Restricting. If they're already having what? Kidney damage. The urine output should be at least 30 ml per hour and indicates adequate renal perfusion and increased dietary protein and carbohydrates and permit no added salt. So as you can see here, the dietary protein and carbs gives the kidney enough energy to regenerate and heal itself. Administer medication as needed. Okay? The number one thing that they actually administer when they start this is magnesium sulfate. Why did they give this again? It is for the prevention of eclampsia. It is for the prevention of eclampsia. Just remember, once the woman goes into the pre-eclamptic stage, that actually puts her at very high risk of going into eclampsia. Right? So remember what I told you about the assessment. How do they determine if the woman that is pre-eclamptic is going to go to eclampsia?
Blood pressure?
What do they check? The tendon.
Oh, okay.
Remember what I showed you guys? They check the knee reflex, they check the ankle reflex. If it is hyperactive or hyperexcited, that means they're going to go to eclampsia. What do they give to prevent it?
Magnesium sulfate.
What is something again that they monitor closely when they're giving magnesium sulfate?
Respirations.
The respiratory rates.
Perfect.
You said that because it can cause respiratory stress. So we know that it's very toxic. So even though we know it's going to do good to prevent eclampsia, we want to make sure that we're monitoring the patient's respiratory rate. Okay, so in reality, you want to make sure that once the woman is started on magnesium sulfate, that they can maintain a normal vital signs. Normal blood pressure, normal heart rate, normal, especially respiratory. Very good. So here are some of the signs that can actually tell you that they probably have magnesium toxicity. And don't worry, I'll give you guys this copy. Blushing, sweating, hypotension, depressed deep tendon reflex, central nervous system depression, respiratory depression. All of that is signs of possible magnesium sulfate toxicity, and the antidote is calcium.
Gluconate.
Monitor closely their neurological status and periodically assess the deep tendon reflex. Make sure that is intact. Okay, so how do we do the deep tendon reflex again? Knee jerk,
Yeah.
ankle. Monitor the client for
Knee jerk and
any
ankle jerk.
signs of worsening preeclampsia,
Knee jerk,
especially their
ankle
blood
jerk.
pressure, and possibly
Knee jerk,
prepare the
ankle
woman
jerk.
for induction of labor.
Knee jerk, ankle jerk.
Take note. Want to make sure you guys are aware of this because they're going to ask you.
Okay.
If the woman is actually having complication related to preeclampsia or eclampsia, don't forget, if the question is, what should the nurse do first? Take note, to monitor first the what? Fetal
Heart rate.
That's the priority. Okay? It's the priority, fetal heart rate, because the baby, they cannot take so much changes. They're the one who's going to die first. In that situation, we need to monitor the fetal heart rate because if we see signs of depression, we should prepare the woman for possible what?
Sir?
C-section. Okay. Always remember that. Okay. The other thing where that comes out is when, you remember our discussion yesterday or amniocentesis?
Mm-hmm.
There's a question where it's asked, what is the responsibility of the nurse during amniocentesis? The answer is monitoring the fetal heart rate. That's the responsibility of. Just remember, an accidental puncture can happen, and if the baby gets hurt, we have signs of distress, we need to prepare the woman for possible
C-section.
So prioritize fetal heart rate before we take care of the mom. The mom is old enough, she can handle a lot more of the changes compared to the baby. Okay, is that clear, guys?
Mm-hmm.
Okay, good. So just don't forget, here is the nursing consideration for eclampsia. So eclampsia is when the woman goes into seizure already. Here are some of the things to remember. Seizure typically begins with twitching around the mouth. The body then becomes rigid in tonic muscle contraction that lasts about 15 to 20 seconds. During that time, it's not just the woman that cannot breathe, it's also the
Baby.
especially when the woman's diaphragm becomes paralyzed. The facial muscles and then all muscles alternately contract in rapid succession, and respiration is appropriate. So that's why throughout that process, especially when the woman stops seizing already, we immediately monitor the fetal heart rate. Again, if there is signs of depression on the newborn, we need to prepare the woman immediately for C-section. Maintain a patent airway, administer oxygen as needed. In this situation, what is the method of administering oxygen?
A rebreather?
Non-breather.
Because if you want to deliver pure or high level or high concentration of oxygen, a nasal cannula can only handle less than 6.
Okay.
But if you want it to be more than 6, it's a mask. Remember though, you have to do it when it's safe, not when they're tonic seizing, right? Why? They can strangulate themselves. So you have to wait till that happens. Monitor the fetal heart rate as the priority and administer medication as needed. No, even though it's just a mask, a simple mask will be enough. If
Simple
it's
mask?
asking you though to deliver more than 10 liters, if that's what you want, a non-rebreather. Now, if the question is you want accurate concentration of oxygen, that's when you use the Venturi. Have you guys seen the Venturi mask?
Yeah.
The one that has a V tube right here,
Mhm.
where you can actually dial it. The reason for the dial is if you want accurate percentage of oxygen to give to the patient, that's the best way to deliver oxygen through a Venturi. But a simple mask is the right answer. You don't have to pick any other mask. Simple mask. Alright. Our next topic, really quick, is on here you go. 2. Placenta previa and abruptio placenta. Very simple. All I really want you guys to remember on this one are the difference in manifestation. Because that's what they're going to ask. Okay, the description. Right? So when you say previa, is when the baby develops, the formation of the placenta is in the wrong place, right? It's always towards the lower portion, either on the border of the cervix, right here, close to the cervix, or partially covering the cervix, or completely covering the cervix. Right? So you have a placenta that's actually in the wrong position because the placenta, in normal position, where should it be? Here, right? On the fundus, right here. Because the sequence is baby comes out first, followed by the umbilical cord, followed by the
Placenta.
placenta. So that's why the placenta is always on the top. Now, if the placenta goes to the bottom, that's what we call previa. Now, so how do we describe previa? It's actually bright red bleeding that is non-tender with soft abdomen. Okay? So if the description is bright red bleeding, non-tender, meaning no pain, right? And it's a soft abdomen, what is that?
Placenta
Placenta
previa.
previa. Is that clear?
Mm-hmm.
Yes? And we're not supposed to perform what?
Blood pressure
Vaginal
assessment.
Okay. Bright red, non-tender, soft abdomen, previa. Now, when is it abruptio? When it's dark red, it's painful, and the abdomen is hard or rigid. Okay? That's abruptio. Now, when you say abruptio, the placenta is in the right place, but what happened is the placenta actually what?
Dislodges.
Detached early. Remember, the placenta is not supposed to detach. The placenta is supposed to detach when the baby has already what? Come out. If this placenta detaches while the baby is still inside the uterus, what's gonna happen? The baby is not gonna get blood
Nutrients, yeah.
and oxygen. So your baby can die during the process of delivery, right? So in this situation, how do you know that this is an emergency situation? If the blood that's coming out is dark red, if the patient is having a lot of pain, and the abdomen is hard. Okay, is that clear, guys?
Yes.
Don't forget that. That's all you really need to know about. At least you also know what's the problem with previa and abrupt. Alright, so here's an example of how this can be on our NGN, so-called blood. The nurse is caring for a client who's been diagnosed by abruptio placenta. What signs and symptoms of abruptio placenta does the nurse expect to find in this client?
Tenderness, no. It's wait, no, abruptio. Yeah, 3.
1, 3, 6.
We have, do we have vaginal bleed?
Yes. I put some. No. Yeah, 1, 3, and 6.
Yes, not really decreased bundle height.
No.
Do we have uterine tenderness?
Yes.
Yes. Is it soft abdomen?
No.
No, that's previa, right? Abruptio. Hypotonic small uterus?
No.
Abnormal fetal heart tone?
Yes.
Yes.
1, 3, 6.
Remember, our description did not include hypotonic small uterus. The soft abdomen is for previa. We also did not include
That's-
decreased bundle height.
Happy birthday!
Yes, guys, it is her birthday.
Happy birthday to you. Happy birthday to you. Happy birthday, dear Miss Sally. Happy birthday to you.
I know. She's cute. So like, she's not gonna cry. She doesn't cry. You cry. I said, I know, but when she's touched, it's different.
That's fine, here. I just, because I won't be here before you guys start.
Those balloons are a typo.
No. Maybe some words of encouragement.
That's great.
Yeah. So I was with you guys in the beginning.
I know. You know, you
And now
said
you're.
Mr. H.
Oh, no.
You know what? You know what I say to that? Liar. You know what I was there.
This is not Dr. Harris' class.
No,
This
it's
is
not.
Vivian
That's
Williams'
right. You're my
class.
class.
Remind
Study
Because
guide.
you know what?
You didn't meet Miss Ely yet.
It must have worked. Now you're here, and you're gonna take your exit,
And you're gonna pass it.
yeah, give it, pass as a birthday gift.
There you go.
And I'll be in tomorrow before you guys start. Pray with you guys, affirmation, start my exam. When she gets here, I'm jumping back in.
You know, I'm not the mushy one, so. But you guys, I'm gonna miss you.
Uh,
And tutoring you every Thursday at 7. For years. But you guys, healthcare is really lucky to have you guys as nurses. It's really, really.
They sure are. Especially me.
Okay? Yeah.
I'm charging extra.
Yeah. This is a good cohort. This is a cohort that I feel like in a long time that I'm like, yeah.
Especially the end, right? Mr. Montano, right?
Yeah, of course.
I don't even know.
Okay. Continue. Bye.
Bye.
This is it. Special business. That's good luck. So, yes. Going to upload this also because I need this together this APN on pre-eclampsia and postpartum. Alright, so I just want to give you guys a example of how the preeclampsia NGN can actually come up. Alright, so here it is. Alright, you guys got this, okay? The nurse is caring for a client admitted to the labor and delivery unit at 35 week gestation with preeclampsia. So we're kind of like towards the end of the pregnancy because we're already at 35 weeks, right? That's like almost at the end of preterm. We're going into term, right? So how many weeks again is term?
37, 40.
Weeks, right? Very good. Okay. So the question is, click to highlight 4 findings that are most significant for preeclamptic patients.
Blood pressure. Shortness of breath.
Alright, so what do you think are the 4 most significant here? If you were to pick.
Shortness of breath. Respiration. Reflex. Yeah, I'll go with that. Shortness of breath.
Reflex is gone. What do you think could be a sign of what could have happened when the reflex is gone?
They're too much on magnesium. So.
Huh? What do you think is the reason why yes reflex gone?
Too much,
Magnesium.
too much magnesium.
Magnesium toxicity. There you go. Right? Magnesium toxicity. So blood pressure is also dropping, meaning signs of
Too much
magnesium
magnesium.
toxicity. Respiration is also dropping, signs of
Magnesium toxicity.
toxicity. Okay, and the patient's now having
Shortness of breath. Magnesium toxicity.
Sorry. Yeah, we're only picking. It just highlight the things. If you were to pick of all of the things that have been highlighted, that's how it is on an NGN. Which of the highlighted ones would you pick your top 4?
So those are the more than for shortness.
Correct. Because your shortness of breath is an example, right? So you have your, if you look at this, then your airway, breathing, and circulation. So you have to follow it. So it explains here.
Yep.
Right.
Oh, it's that blood pressure.
So if you
Your
look at
output.
it, they all prioritize your airway and circulation. Prioritize your airway and circulation. So the answer to this one, they picked it.
Reflexes.
This. I had one question though on this when I looked this up. Because this one is also a priority.
Mhm.
Okay, that one's also priority.
Yeah, but that's not an option.
Although, when I asked API about it, is that the reason behind it is because you already prioritize respiration here, which is they already what?
Okay.
Depression. So that already comes up with that. You don't have to take the 92. And you they actually take in shortness of breath.
So they don't do blood
So
pressure.
that's an example of how the cues again will actually come up, and they want you to pick the top 4, or the top 3.
So,
Here's the rationale. Magnesium toxicity is characterized by respiratory depression, decreased urine output, and loss of deep tendon regions. Spontaneous flushing and sweating are expected side effects of the magnesium administration and not concerning. The blood pressure at 9 is expected since the client has severe preeclampsia. Magnesium infusion can cause the hypotension to happen. So it's expected, the lowering of the blood pressure. So basically, what the priority was, if you think about it, why they actually picked this,
Oh, they're out of range.
shortness of breath, because those manifestations are something related to
Magnesium toxicity.
magnesium sulfate toxicity.
Yeah.
Now, why was it though? Anyone can explain to me why the blood pressure wasn't prioritized?
Still within normal range?
It's still about.
Why? Because to begin with, this was actually a problem.
Yeah.
You were pre-eclamptic, right?
Yeah.
So the blood pressure going down is not really a big what? A big problem, because the normal blood pressure is systolic between 100 and 120, diastolic between 70 and 80.
Okay.
Very good. Here's another one. The next thing also on cues, it's asking you now that based on this, what additional assessment data should the nurse obtain? So the additional data that should be prioritized is the fetal status. So as we said, always monitor the fetal heart rate, breath sounds, and level of consciousness. So basically what happened is on this, they gave you additional information that you need to gather more information about that area. And if you look at it, it's again going back to airway, breathing, and circulation. Let's see, why did they pick fetal status?
Oh, if they're losing 2% of blood, the baby's also.
Let's read it.
Oh, the oxygen.
9 a.m., 4 grams loading dose of magnesium sulfate IV started to be run over 20 minutes. The second nurse verified a pump setting. Client educated on medication side effects. The client complains of headache rated at 7 over 10. No nausea or vomiting. No epigastric pain, no visual disturbance. Current blood pressure is 159 over 89. Fetal monitor shows baseline heart rate at 130 beats per minute, moderately variable, acceleration present, and deceleration absent. Magnesium sulfate loading dose, change second nurse verified the pump, client noted to have her breathing, flushing, and sweating. Fan was brought to the bedside, absent paternal reflex, respiratory 11, and complaints of shortness of breath and falls of sickness. And the question was, what additional sets of information or data the nurse needs to obtain? Select all of the blood. So if you look at it, pupils, there's nothing relating to what? Your pupil. Right? It didn't say that they have any pupillary light reflex problem. And also it tells you that it says here, so that already tells you, well, there's no need to check the
Medication, sir.
the other one, sensation. Is there a problem that we should check sensation?
No.
What tells you that that should not be something that we have to get additional information from? What tells you? Anything that tells you here that you don't need sensation?
Absent patellar
The
reflex.
patient is able to give what? Feedback related to complaints. That means that their what? Their sensation is intact. They can tell you I have a headache. They can tell you I have pain. They can tell you if I have discomfort. So there's no need for checking that. Capillary refill. Is there a problem with capillary refill that we need to check it? Do we have any issue related to that? that we need to
No.
check?
There's nothing on circulation.
No, right? Okay. Now, question: why fetal status?
To check if
Well, they have to face.
the mother's
baby
deteriorating.
at
Yeah,
baseline. What's our normal? 120 to
60.
160. So meaning they're close to what? Going
Baseline.
down. So we need to monitor that. Breath sounds. Why do we need to monitor breath sounds in this situation?
Respiratory rate was really low.
The patient has complaints of
Shortness of breath.
of breath. Why do we have to determine level of consciousness?
The headache or
Headache,
Visual,
but then other than that,
visual
also
disturbance.
I'm sorry,
pulse off.
part of the cause of magnesium toxicity.
Okay.
Remember, when someone has magnesium toxicity, other than it can cause low blood pressure when it's so severe, low respiratory rate, low heart rate. Another sign is, can you easily arouse someone on magnesium toxicity?
Oh, no.
They're not a what? They're not awake. So that's why someone who's on magnesium or magnesium sulfate, we always want to check the level of consciousness. Because if they're hard to arouse, what is that a sign of?
Magnesium toxicity.
If they're hard to arouse, what is that a sign of? Magnesium toxicity.
I get it. Each other.
Now, it's not going to be exactly like this, but I'm just going to show you, like I said, some of the things that they can ask you on pre-eclampsia. So what's the third question on NGN? What's the third question again they ask you on NGN?
What they're
The problem.
experiencing.
What is the problem?
Magnesium toxicity.
What tells you that it's not abruptio placenta?
No bleeding.
No
The
bleeding.
patient doesn't have dark red bleeding,
Mm-hmm.
doesn't have uterine pain, and did it say that the abdomen is hard or anything?
No.
It says soft, right?
Yeah.
Why not eclampsia?
Blood pressure's
There's
low.
no mention of seizure.
No seizure. Yeah.
Right? Why not pulmonary embolism? Because there's no evidence of what? Blood
Blood clots.
clots. No evidence of blood clots. Pulmonary embolism is something that you could pick if this was a case of blood clots. Or what's another case that you can pick actually pulmonary embolism? Fractures.
Mm.
So again, always expect that the third question is it's going to ask you the problem. What's the fourth one? That you're going to ask you, what do you think?
Plan of care.
The here. There you go.
It's just
It always follows the scene sequence. This is an example of how the plan of care they're going to ask of what can also be on your.
Okay.
They give you the plan of care. You said whether it's what?
Indicated,
or
not indicated.
Stop the magnesium sulfate.
Yes,
Well,
indicated.
Obvious, right? It's what? It's
Indicated.
indicated because it's a problem of what?
Magnesium
Toxicity. Number two, obvious also.
Yes.
Why? Because that is the
Antidote.
no. Place the client in a supine position.
Not indicated.
That's hypotension.
You have shortness of breath, so
Yeah.
what should be the position?
High follows.
Left bladder. Oh.
Right? Okay. Activate rapid response.
Indicated.
Yes. It's an emergency. They're on what? Magnesium
Magnesium
toxicity.
toxicity.
Provide oxygen.
Yes.
Indicated.
Yes. Oxygen saturation is
Low.
dropping.
Yeah.
Monitor the fetus.
Yes, indicated.
Right? Administer anti-seizure medication.
It's not even.
Not indicated.
Not having it. They're actually what? They're actually depressed. CNS depressed. So why would you give more anti-seizure? That would be wrong. Draw serum magnesium level.
Yeah.
Yes.
Check for the medication error.
Yes.
Possible because of what? The dose. Why did the woman go on toxicity?
It was too high.
Check. What happened? Elevate the extremities.
Return.
Yeah.
There's no
This
need.
DVT.
What's the next one?
Evaluate the.
So I'm going to show you an example of implement.
Oh yeah, implement.
Implementation, but it's asking you 3 actions that the nurse should take first.
Okay, stop the infusion.
Stop magnesium.
Right.
Okay.
In this situation, because it's a problem of magnesium toxicity, the first thing they do is stop the magnesium, administer the antidote, and activate
The rapid response.
What is the last one that they will ask?
Evaluate the.
Evaluate.
Yeah.
So it says, let's take a look why it actually said that. It said, the nurse determines that the client's status is unchanged, and the nurse should now request additional dose of calcium gluconate. Why unchanged? From 12 to 12:15, the respiration is
The same.
Heart rate is
Similar.
the same. 1 point is not a difference. Remember, point significance should be greater than 5. If it's not, then it's not. Blood pressure, it's the same thing also, right? From 92 to 93, not really
Yeah,
a problem.
similar.
So in this situation, if you look at it, the situation is not good, but it is also what?
Not getting worse. Yeah.
It's unchanged, and that's why the other one is, why did they pick request additional dose of calcium gluconate?
Because
Why
it's not working.
Resume magnesium sulfate infusion?
Because the problem's still there. The toxicity is still there.
It's a case of toxicity, right? Why
Yeah.
would you give more? So it rationalizes that. If I give this and it's a case of toxicity, then I will make it worse, right? So transfer to, this is your only options here, either to transfer the patient to ICU or give them additional calcium gluconate. So what should be your immediate action? Give them additional calcium gluconate and activate the ICU for immediate response if you needed the emergency. So that's why that was the evaluation that was made. It's unchanged, give them additional calcium. Again, could be the same thing, could be not, but this hopefully at least helps so you can see what goes on in the
Mm-hmm.
Now, any question?
No, it's good.
It's a lot of information, right? Okay, so really quick, I want to just mention one thing on Peds. They're gonna ask Wilms tumor. Okay, now who remembers nephroblastoma? What is it?
What is it?
Wilms tumor is a tumor of what?
The kidneys.
The kidneys. Very good. That's basically what it is. So remember, when that question comes up, that they're asking you what should be the plan of care for a newborn, possibly with nephroblastoma or Wilms. So don't forget, that's the same thing. Okay? Nephroblastoma.
Don't palpate the abdomen.
They're the same thing. They're a congenital type of tumor that actually grows on the kidneys of the newborn. What you will notice is that newborn with nephroblastoma or Wilms usually has a very distended abdomen when they come out. Okay, you'll be surprised. How come the abdomen is so distended? What could be causing this? Right? In that situation, you don't know what's causing it. Do not palpate. Right? Do not touch. Do not press on the abdomen. Although, part of abdominal assessment, what do? We inspect, we auscultate, we percuss, and we palpate. In this situation, do not. Okay, why? That tumor can actually end up
Metastasize, yeah.
It's very sensitive to pressure. If that bursts, then you can have permanent damage or loss of kidney of the newborn, and you're going to end up dying. Okay. So in that situation, make sure that you actually do not touch it, report it immediately, and they will do an imaging scan to make sure if it is Wilms tumor or nephroblastoma. Okay. All right. Any question? All right. Next one. Really quick. We need to go to mental health. Cystic
Fibrosis.
fibrosis. What is this? Who remembers what cystic fibrosis
Sick,
is?
mucus in the
It's a genetic disorder that makes the body produce what?
mucus.
A lot of mucus. Two things that you have to remember, that's the priority. This is what they'll ask. The number one priority is airway. The number one priority is airway. Cystic fibrosis patient, everywhere in their body, whether it's the stomach, the intestine, especially the lungs, the body produces a lot of mucus. Like really heavy, thick mucus. So what does that do? It actually clogs the airway. So what happens is you'll end up having children or young adults not being able to breathe. So the priority is making sure that we're able to help this client to have an easy way of breathing, clearing the airway. That's the number one thing. Okay. So very important. What do you call this? They'll ask this.
Cupping?
Physio.
Oh, physiotherapy.
Very
Okay.
good. Physiotherapy. It is important that the patient gets regular physiotherapy to loosen the secretion so that they can be able to breathe easier and cough it out. Because remember, as the secretions get thick, the more secretion is produced, the more the airway is going to be blocked. If we do that, do the physiotherapy and encourage them to learn, cough, and deep breathe. That will help clear out the airway so that it will be easier for them to breathe. Okay. The next one, very important to know, other than breathing, they have a problem with digestion. Which type of food can they not digest?
Fats.
Good. Fatty food. They cannot break down cholesterol. They cannot break down fat. Now, what's the reason behind it? What's enzymes they're missing?
Pancreas.
Pancreatic
That's
enzyme. Very good. Their body is missing pancreatic enzyme. Right, so that's the next thing to remember. Their body is missing pancreatic enzyme. Without pancreatic enzyme, their body cannot digest fat and cholesterol. So what do we do? What type of modification do we do?
Get it. Alteplase, whatever.
They can also be given pancreatic enzymes. And make sure it's given before they eat. Reduce the fat, so low fat diet, and administer pancreatic enzymes before.
Enzymes before meals.
Okay? Those two. Just remember those two were good. With cystic fibrosis. Any question on those two? Good?
Yep.
Alright, last one before we go on. Are we gonna go on a long break or what? What do you think, guys? No. Or just continue and finish.
Let's finish.
Early then. We can go.
Yeah, let's do that.
So last one, you have to remember before we go to mental health. Umbilical cord care. Okay, for the newborn. Alright, so don't forget, do not get it wet. If it does get wet, you want to make sure it's air dry. So do not put it inside the diaper. Leave it out in the open air. Okay? Alright, and also make sure that you don't manually remove it. It should actually fall off on
So,
So,
fall off on its own. Okay. So that's why, what if they still have the umbilical cord, do not immerse your baby into the water. Sponge baths, head baths and sponge baths. That's what you need to do. And do not get the umbilical cord wet. If it does get wet, dry it up immediately using hair dryer. Okay? Alright, very good.
what you did.
Man, not that bad yet, okay? I know we're going fast, but we need to. Alright, here we go, mental health. First one that they will ask you, mental health, domestic violence, okay? So this is what we call as intimate partner violence. Intimate partner violence, IPV. Or in this case, domestic violence. So the main focus here is, other than knowing the manifestation, is they're gonna ask you the characteristics of the perpetrator and the victim. Don't forget, they're gonna ask you about the characteristic of the perpetrator or the abuser and the abuse. Okay, so here's an example. A nurse in a community clinic is speaking to other nurses about risk factors for domestic violence. Which of the following statements by one of the other nurses indicates a need for further teaching? So it's asking you for something that was said that is
Wrong.
wrong.
Yeah, it's definitely D.
B.
That's what.
Because I'm sure they do that.
Yeah.
Like it's good.
Yeah. I don't know.
It is wrong. Something that was said that is wrong. It says A.
Bless you.
Says B. Says C. Says D.
Hey.
You'd be surprised. The answer is actually B.
Yep.
Wrong.
Yep.
I have heard that
Yay.
abusers think of themselves as important and have high self-esteem. Abuser actually has low self-esteem.
Yeah, they want to put it on others because they got low self-esteem.
Lower
Yeah.
than who they are. To hide who they are. Remember, abusers, in reality, they're the weak ones. That's why they try to overcome you, right? With physical abuse. Alright, so again, abusers have low self-esteem. Okay, so don't forget that, guys. Okay, we'll discuss more as we go into the content. Okay, but remember, also abusers have the tendency to be the victim themselves.
Mm-hmm. It's a
Also
cycle.
in the beginning, they have a family history of
Abuse.
having like abusive or perfect type of perfectionist type of family. Okay. Right, and this, correct. Abusers try to keep their partners isolated. That's how they keep you from, from progressing and overcoming the abuse. They'll keep you isolated from your friends. They won't allow you to grow. I know that abusers lack social support and social skills. They do. They don't. They're more of introverted type of individuals. And I know that men who are abusers gain power through intimidation. Yes, intimidation and physical violence. That's what it is. Next, a nurse is talking to a client and is explaining about the home situation and the intimate partner violence you recently experienced. Which of the following responses should the nurse make? So, I put this here because a lot of your other questions on mental health is therapeutic
Communication.
Okay, so just get used to the therapeutic communication process.
Is that A or D?
Therapeutic communication. The answer is
D.
D. I'd like to hear more about how you are feeling. Can you tell me more about this? Can you give me more information on the event? That's what you want. You want the individuals to what? To elaborate. So a few things important to don't take answers that starts with Y. Okay. The next one, now that you have come for help, you will feel much better. What is that?
Also reassurance.
It's gonna be okay. It's never okay. Someone says to you it's gonna be okay now. That
Lying.
person is probably lying. Alright, let's talk about what is going on at work. Work is not.
Yeah.
Alright, an emergency department nurse is caring for a client who is becoming increasingly agitated. So, other than abusers being low self-esteem, they're also quick to agitation. Go up. Okay, now, there's a question on your exit on how you handle patients that's becoming agitated or what do you call this? Violent. Which of the following action can the nurse take first to decrease the risk of violence from this client?
C maybe?
There's a clue.
C or D?
Yeah, there's a clue. So what's the answer? Assess. Assess your pain level and intervene as
Oh
necessary.
yeah, duh.
Probably asking one.
Let's take first.
It's a process of assessment, but here's the other thing. A lot of times pain, it can be physical, it can be emotional, but a lot of times people are aggressive because they feel what?
Threaten.
They feel
Open.
that's what it is. So in that situation, remember, what is the clue? You see
First.
this on your test, when you take the exit, look for what kind of answer first?
Assessment.
Assessment. Jump into that. If it's an assessment answer, pick that. Tell you that's the right answer. Because let's take a look at the other option. Would you place an agitated patient in another client?
No.
When they're agitated, you're supposed to what?
Separate.
Not seclude, okay? Ask the family member to wait in the lobby. What
Maybe.
would that do?
Yes, it's relevant.
Answer the problem, solve it. If they're
No.
agitated, no, right? Move them to a room away from the nurse's station. That's wrong. Right? You
Yeah.
want them where?
Close
to
to-
the nurse's station.
For observation.
Alright, so here's another one. This one though is on psychosis. Alright, the nurse is caring for a patient that told the nurse, "You are all FBI agents trying to catch me, make a mistake." Right? What should be the response of the nurse?
C.
I want to say B, but it's
Hey,
It will be
we are
funnier,
not
but yeah, it's C.
FBI agents, we are nurses caring for you.
And then you pick quick C and it was like, oh, you need to be like.
No, it might be A, you know? You're not a thing. You have to.
Okay, what's the best answer? The best
C.
answer is I see.
But
The best answer is I see you are worried. Can you tell me about? Okay, this is very important.
You can't
We're
dismiss
talking
the
about
feelings.
mental health here. So we're talking about, answers that will make the patient what? Elaborate more. So this also applies not just for some patients who are on mental health, but especially on schizophrenia patients. Because remember, for schizophrenia patient, you actually deny what they're telling you.
No.
Do you actually confirm what they're telling you?
No.
No. You don't deny, you don't confirm. What do? You ask what's going on. Right? So let's say in the exit, they tell you that you're caring for a patient with schizophrenia or psychosis, and the patient is talking to thin air. Talking to thin air. What should you do as a nurse? Like,
That's what they're
tell
saying
them
here.
that they're talking to no one, right? B, tell them that, hey, you know what, your friends. What are you guys discussing?
Yes.
Right? No. The other one is ask them what the conversation is about.
Yeah.
That's the right answer. Because remember,
They could be
for
taking
mental health patients, especially schizophrenia or psychosis, the responsibility of the nurse is not to determine whether really they're talking to someone or not. You want
safety.
to get the message, right? Because the message is what's important. Because they could say that, oh, burn the facility, right? So, kill the nurses, right? So here's another one. Another situation, mental health, okay, psychosis. Think of that, okay, so that you have a clue already. Psychosis, mental health patient, the nurse caring for this patient that told the nurse, open the gate of hell for me. Okay, what should be the response of the nurse that requires the charge nurse to intervene? So the nurse said something that, yeah, don't say that.
A.
The answer is B. There is no gate. Okay. What did we say? We do not.
Yeah, confirm.
We do not deny.
Deny. Oh, okay.
Okay. Here's the thing. What I want you
What's wrong?
to know: if you deny, and this is a psychotic patient, they're gonna become increasingly agitated. Why? Because for someone who has psychosis, if they see the gate, that gate is what?
Real.
That's real. That's real. So when it's real, your responsibility is not to tell them whether it's real or not. Your responsibility is to find out what? The message.
Mhm.
Why they see that. Because it's a priority of safety. That's what it is. The responsibility of treating the diagnosis is not the nurse, it's whose? The doctor.
There is some point you would encourage it or not. First, like, you would, assess it. If it was 9 years or.
Were you correct?
Yeah,
Were you
correct. Is there
reordered?
any-
Yeah, there's a scenario like that. So one of the, not really correct them, but the answer is divert their attention.
Oh.
Or like, what do you call that? Put their attention or focus on something else. Here's a situation. Like the same way as earlier. I told you that the nurse sees the patient talking to someone else, right? So your first response should be, can you tell me about the conversation? Once the patient tells you about the conversation, directly tell them there is an activity going on in the activity room or on the patio that's going on. What did you do? You actually redirected their attention because remember, one of the plan of care for psychosis is to stop them from hallucinating. And when you stop, you don't tell them, stop hallucinating, right? You don't do that. What do? You put them in a different
Okay.
take them out of that situation. In that situation, that's redirecting. Redirect. Take note though, because we're already on psychosis. When you take a psychotic patient, do not pick an answer that you take them to their room. That would be the worst thing to do. Okay? Don't take them to the room. Why? The room is very secluded. There's not enough space. They will hallucinate more. Can you take them in the activity room? Unless it's safe, you can. But if they're having hallucinations, it's better to take them where? Into a room that is more space. That would be the best answer. Your next best answer is activity room, but the best answer is more space. Like where? In the garden, like the patio. Because where they can have more space and relax their mind. Okay, so do not pick taking them back into the that's also the same thing if the question on bipolar comes up. Remember, manic patients are not supposed to be taken in a closed room. They're supposed to be taken in an open where they can actually move around. Because that's what bipolar is, right? They can't stay in one place. So where do you take them? In a room that has more
Space.
space. Same with psychosis. Okay, so, very important to know, here it is, please remember this on this page. This is what you're gonna ask, characteristics of the abuse and the characteristics of the perpetrator. So, take a look, that's the one that we were asked earlier. They don't have high self-esteem, they actually have what? Low self-esteem. They're your perpetrator. So please do not forget this.
Taurus. Can't spell for shit. Alright.
Alright, next one. Other than the perpetrators and the abuse patient, panic disorder. So really quick, very important to know on this one thing you have to remember is that when a patient starts on a panic disorder and they ask you what is the first thing to do, answer, stay with the patient. Don't pick an answer that you're gonna give them teaching or you're gonna give them instruction. Because what? They won't be able to understand that here's the panic. So the most important thing, if this question ever comes up, if they're asking you what should be the immediate action of the nurse, is for the nurse to show that you are there for the patient. You need to say something? No, you don't. You just have to stay quiet and make sure that the patient can see that you are there. That they have someone that they can actually rely on, no matter what happens. So in that situation, keeping them company is the best thing. Okay, now, once the patient starts to relax, that's the time that you can actually give them instruction. But the instruction should be focused on breathing techniques. That's the first thing you want to teach them. Okay, why? Panic disorder patients are hypoventilating or hyperventilating. They're hyperventilating and they can go into respiratory
colossus.
Good. So what do you want to do? You want to make sure you prevent the possible development of respiratory alkalosis and you give them instruction on breathing techniques. Breathe in, breathe out first.
Respiratory
The first instruction you want to give. The other things can follow. But it's important that first keep them company to make sure that they know there's someone there. Once they start to come down, what do you teach them?
Breathe. Yeah, deep breathing.
And that's really important on panic disorder. Alright, next thing I forgot, we already passed the abuse and the abuser, but there's, just remember, there's a question on characteristics, but evidence of abuse, okay, especially in children. They're gonna ask you on what are possible evidence of abuse, okay, so let's go ahead and make a slide. Going back to mental health, do you guys remember what are possible signs of childhood?
Injuries at different stages of healing. Spiral fracture.
Number one, I heard the fracture. What
Spiral.
is it? Spiral. Okay, so be careful with spiral fracture. This is actually correct. But remember, the spiral fracture has to be a spiral fracture of the arm. Okay, take note. Because if the description is spiral fracture of the leg, don't pick that. That's the wrong answer. Okay, because spiral fracture of the leg can happen even if it's not an abuse. There is a higher risk that it's abuse if it actually happened on the arm. There's a possible twisting of the arm if they're trying to run away. Okay? But the leg, it could be caused by, rough play or falling down, so not really a play. Any other signs of child abuse?
Injuries at different stages of healing.
Very good. Different stages of wound
Wound healing.
healing. Okay, also shapes. If the
Okay.
wound has shapes, certain,
Okay.
like burn marks, belt buckles, okay, have actual shapes. Also different stages of healing, meaning you have some that are healed already, some that are medium, some that are still worse, and
Burn marks.
the wounds are actually what?
Hidden.
Hidden. So don't pick an answer where it's on the arm or on the shin, because what? That's obvious. Abuse are usually what? Hidden. So
Yeah.
meaning by the groin area, the buttocks, the chest.
Side of the body, yeah.
Don't forget that.
They want to stay at the hospital.
I'm sorry.
The child wants to stay at
Very good. The child wants to stay in the hospital and does not want to go home with the parents, right? Right? The other one that usually comes up as an answer on our exit, there is a difference between the statement of the abuser and the abused. They don't match. They don't match. There is a big discrepancy
Stories
on
don't.
how the abuser is describing the cause versus the description of the abuse. So the stories does not match. The other one is sexually transmitted diseases in children.
Yeah, okay.
Okay, that's sexual abuse. Yeah. So just don't forget that. That's another example of abuse, STD in children.
UTIs too, right?
Recurrent UTIs, gonorrhea, those things. The other one that also comes up really often is the cause of the injury is it's not possible. The cause of the injury is not possible. So let's say, for example, you have a like 3-month-old come in with a near drowning situation, and the explanation is the 3-month-old went to the bathtub and turned on the faucet. Right? So that is what? An example of the story doesn't match the actual cause of the injury. Okay, that's like impossible, right? As an explanation for the okay. Is that clear? Any question? I can ask you, okay? Signs of abuse. Oh, one thing that I also remember, this comes up. The child does not cry when approached by strangers. So remember, children has what we call as stranger anxiety. They're usually, afraid, or they'll have reactions to strangers. This one just stays quiet. Why? Because the child has experienced that they get hurt if they react or cry. They're gonna get hurt. Okay, so in that situation, that child does not react to encounter with strangers. Okay. Alright, awesome. Alright, next one. Don't focus too much on SSRI. There is one question though that's gonna be on our exit on ADHD. Okay, but not on the situation though. They're gonna simply ask you directly on if the patient has ADHD and they're being given, let's say,
Some sort of meth.
or Ritalin, or the other one is Adderall, right? That's another one, Adderall. How do you know it's therapeutic? What is our measurement?
They finish their homework.
Complete task.
They can
Finish their homework. Yeah.
focus. Finish the task. Okay? Focus or finish the task. That's what it is. Don't forget that. They're gonna ask that, okay? So not so much on SSRI, but more on don't forget focus. I'm sorry. You don't do this.
Focus or
For
finish.
Adderall, it's very good on focus, but it has a burnout at the end.
Validate.
You might lose your mind. So don't. As long as you pass it, don't lose your mind.
Separate.
Alright, next one. 2 eating disorders that they're gonna ask you, okay?
Anorexia and bulimia.
Anorexia nervosa and bulimia nervosa. Okay? Alright. First thing to remember here, write this down. They're gonna ask you on characteristics of patient that develops bulimia and anorexia. Don't forget, they're usually women and they're usually what? Young.
Young.
Not really old, but more of what? Young. Young women in their teens or young adults. That's usually it. Okay? What's the other characteristic? They're usually what? Perfectionists.
Perfectionist.
Usually perfectionists. With a strict family upbringing.
Strict family.
There's what? High expectation in the family. They usually are associated with stressful life events, especially changes in the college or school. Another one. Okay. So just don't forget those characteristics. Okay. So female, not so much males. Okay. The other thing, if you think about it, anorexia, they're the one who eats or do nothing.
Don't eat.
They do not eat, right? Bulimics, wow, they eat a lot, right?
Yeah.
So what do?
Purge.
Purge, right?
Purge and purge.
There's guilt at the end of eating, right? The guilt at the end of eating actually causes them to purge, right? To bring it out. Okay, that guilt that, oh, I ate too much, I'm gonna purge myself now. Okay? So, but they're both eating disorders. Right now, the more dangerous one though is the
Anorexia.
anorexia or bulimia.
Anorexia?
Anorexia, right? Because what? They don't eat. They can die of severe malnutrition, dehydration, okay? The electrolyte imbalance, all of those things can happen to an anorexia. Okay? Plus, anorexics, they also purge. If they think that they're actually eating meat, even though they don't, they're gonna purge also. Right now, both problems though is a problem of, and they're gonna ask you this, body dysmorphia. Okay. So, does everyone know what body dysmorphia is?
Yeah.
Right? They see themselves as different. Okay.
Dysmorphia.
So body dysmorphia is when you look at yourself and then you see yourself as overweight, but then in reality you're already what? Skinny. So here's the thing, the next one they're gonna ask you, how do you determine if the patient is getting better?
Electrolytes.
So two things, correct. So
EMI.
the first one is anorexic.
Okay.
What is the first stage of determining if an anorexic is getting better?
Weight gain.
Weight gain other than weight gain, because they're not gonna start.
Electrolytes.
What do? They start talking first about what? Food. So take note. Anorexics, they never like to talk about food. They don't
Okay.
even want to discuss it. It's something that they try to what? But once the patient starts to get better through therapy, and sometimes also through the use of SSRI, okay, then this individual would start to open up and start to talk about food. Okay? Start to talk about food. Okay? That's the start. At least you'll start discussing about what would be a good dinner, what would be a good lunch, what would be a good, snack. And then eventually you will see that they will start taking what? Bites. Food. They'll start eating. That's when the weight gain starts to happen, right? Okay. So you won't see the immediate weight gain though, but the discussion of food will open up. Now how about for bulimic? Okay.
How much should they be gaining each week?
Well, it's not really a matter of how much, but rather it's more of do they start to eat? Do they start to eat? So the first progression of what you will see is even though they don't eat a lot. So let's say you give them a small portion and they say they eat 50% of it. Even though they start at 25%, then 50%, 75%, then 100%. The mere fact that they ate 25%, is that a progress?
Yes.
Is that therapeutic for the patient?
Yes.
Yes, because at least they what? They touch the food. Okay, and eventually, of course, you're gonna need to see that they're eating as much as 75% or more of the food. But if the question, and that's again what they're gonna ask, early stage of therapeutic effect, they start eating some food. Now, how about for a bulimic? How do you determine their therapeutic stage? They don't. You monitor them after they eat to make sure that they don't what?
Vomit.
Purge. Or a decrease in the episodes of purging. Usually though, it will take a few minutes. So anywhere from 20 to 30 minutes after they eat, that's when you want to watch them. Because they have to feel that guilt first before they start purging. So it takes time. So about 20 to 30 minutes, watch them after they eat to make sure that they're not what? Purging, or you have a decrease in the episodes of purging. Alright, the next one that they're gonna ask you this. A lot of this patient, both of them can also go into the stage of depression. But for their depression, it's actually better treated with
ECT.
Alright, so what's the acronym ECT?
Electroconvulsive therapy.
Electroconvulsive
therapy.
Okay, so in
It's for both or just one?
Shock. Electrocution.
Is that for both or one of them?
Whether it's one episode, 2 episodes, 3 episodes, it depends, right? On how they'll get the therapeutic effect from ECT. Now, the important things to remember, okay, very important to know. The two things that usually happens as a side effect of ECT is that you get a seizure, and the other one is short-term memory loss. Okay, now the question is, when does the seizure set in, and where does the short-term memory loss set in? So seizure is during the treatment. So don't forget, you have to teach them, and also the faculty, that they should know that ECT will cause seizure to the patient during the therapy. During the shock, you're gonna have seizures. So that's why, part of ECT is that the patient is placed NPO before the procedure, at least 8 hours before the procedure, and they're actually given soma, or a muscle relaxant or flexorant, right? What is that for? To decrease the seizure. So you have to tell them you will experience or get a seizure during the treatment, okay? And there is a temporary short-term memory loss after, not during, but after the treatment that can last for a week. Okay, that can last for a week. So that's why it's important for us to tell the family that you're gonna need to reorient the patient. You're gonna need to reorient this patient after the treatment because of that short-term memory loss. Is that clear, guys? So two things: seizure during, short-term memory loss after. Very good. So ECT, okay? Alright, next one. ethanol, and then we go on a very short break, okay? So hopefully we'll be able to finish soon. The focus though here, guys, okay, is the plan of care. Right. So the question though is the plan of care on delirium. They're gonna ask you on alcohol withdrawal delirium. Okay? Alright. Now take note. There's actually two medications that can be given to an alcoholic that's going into rehab to prevent them from going into withdrawal delirium. Same medication you give for seizure. Lorazepam or Ativan. And the other one is diazepam or Valium. One of them, either one, you can give either Valium or Ativan, and that will help prevent the development of withdrawal delirium. Okay, now, you know, a lot of times for an alcoholic, the usual cause of death is during rehab, when the body starts from alcohol. Why? The body is so used to alcohol. If you take it away, all of a sudden, what happens? It just shuts down. So that's why in rehab, you know, in rehab they actually give alcohol.
Yeah.
Give them alcohol. Just to, like, you know, slowly taper it. But to prevent them from going into delirium, they're actually given either Ativan or Valium. Okay, now, delirium, this is a medical emergency and manifestation includes, again, severe disorientation, psychotic hallucinations, severe hypertension, cardiac dysrhythmia, and the process of delirium or hyperthermia. If you go to hyperthermia. Okay, the alcohol withdrawal delirium can progress to death. Alright, so the other thing we're gonna have to remember. They'll be asking you this. Alright, the plan of care. So plan of care for withdrawal is number one, maintain a safe environment, especially from falls. Implement seizure precaution as necessary. Remember, a lot of times when they go to withdrawal, they also develop seizure. Provide close observation, okay, to manifest any signs of delirium. Constantly orienting the client, time, place, and person. Maintain adequate nutrition and fluid balance, and create low stimulation of the environment. So in this situation, you don't really want to restrict visitors, but you just want to limit. Administer medication as prescribed. What medication again?
Lorazepam and diazepam.
Very good. And monitor for covert substance during and detoxification period. Covert is when they start hiding things, you know, like certain medication. So you want to make sure you're monitoring that because they have the tendency to do that during treatment. All right, any questions? You're welcome. All right, so let's go on a quick break. Alright, really quick. That's the topic. Defense mechanism and dementia Alzheimer's. So this is an example of defense mechanism. They're going to be asking you on how to identify different defense mechanisms. Okay, so here's an example. The nurse is assisting with a court-ordered admission of a client to a substance abuse program. The client states, "You are all," there's a hint here, "you are all angry at me and wish you could go out and have a drink." The client's response is an example of which of the following defense mechanism? Projection. Very good. The other one that's gonna be on your exit is reaction formation. When you say reaction formation, you're actually showing the opposite emotion. So let's say, for example, you are being kind to someone you like. Yeah, I mean, you don't like. Let's say you hate that person, what you do is you're being kind to them.
I like color.
Be kind, you know. So the other one is, let's say you have a crush on someone, instead of showing them that you love them, you actually tease them. You take tricks. So it's showing the opposite of your emotion. That's reaction. So don't forget that. When you show the opposite of how you really feel about that person, that's reaction formation. Is that clear, guys?
Yes.
Alright, very good.
Correct,
The next one. A nurse is assessing a young adult client who has a new diagnosis of IJA, or idiopathic juvenile arthritis. The client states, the pain in my joints is just a temporary thing. Okay, now, let me see. I did get a question earlier from one of your classmates about positioning for EKG. There was one specific question on it, but let me see before we start. Monique is coming though, right?
I'm here already.
When you're ready, yeah, she's right there. Esther's here, yes. Right. Margarita, Doza, yes.
Yay.
And Rudy.
Yay. Oh.
Everybody's here too. Okay. Well, there you all here. Don't forget to sign, okay? So the question was earlier was on EKG, proper technique of how to perform it. The question though was very specific to just how to apply or what is the teaching or what is the requirement for EKG. So it didn't mention anything about MI, or things like that. So don't forget, as I mentioned before, when someone is having manifestations of MI and they're going to use an EKG, the best position is the left sideline position.
Okay.
Now here's the thing though, there was a left sideline position option there on that question, but the question was not related to MI. And the other thing that I noticed that was wrong on that left sideline position is that it actually said semi-prone. So when someone is semi-prone, that means you're almost, halfway facing down. So you don't want to be semi-prone. That's not the right position. So the best one though, if it's not a question related to MI and just EKG, is the semi-Fowler's or supine position. And you just want to make sure that the patient is staying still. Still, that's very important. They have to stay still. Okay? But yeah, you can, the best answer to that, if it's not related to an MI, is semi-Fowler's or supine. Alright, is that clear on that one, guys? Someone also asked me a question on what is the expectation on the cognitive level of someone who is, how does it, guys? Someone who is 6 or 9 years old. I think that was the question. And it was asking about related to a death in the family. So the one that I've seen, and I actually asked the guy about it, is that a 9-year-old, especially between the age of 6 and 9-year-old, might think that it is something that was caused because of death. That they're the actual reason behind it. Okay, now they said, I also looked it up. 9-year-old already understand that if someone dies, it's permanent. Then they don't really see them anymore. And they have the ability to also see the perspective of other people and be empathetic to the feelings of others. But they do have sometimes a tendency to think that it was their fault. It's the reason behind that because of them. Although they also like to have clarification on how that happened to that person. So it's also good that you explain it even though they're only 6 or 9 years.
6 to 9 years.
Is that clear, guys? So they have the tendency to think that it might have been because of them that situation happened. Okay? Alright? So please don't forget that. Okay, next one. We're going to go to our other topics here really quick. Alright. So I want to go over this question because this is something very similar on what we will see on postpartum hemorrhaging, which is a big part of our exit. The nurse is caring for a 1 hour postpartum mom. Upon assessment, the uterus is at the level of the umbilicus and midline. What will be the immediate action of the nurse?
On the turn document? Yeah.
What do you think is the answer, guys? The answer is letter
A.
Good, letter A. Okay, so don't forget that this is actually, if you look at your assessment of the mom based on the information given to you on the assessment, you will see that at 1 hour postpartum, having the uterus at the level of the umbilicus and midline, there's nothing wrong with that. That's where we really want it to be. Okay, we want the uterus to be at the level of the umbilicus, and it does actually go down 1 centimeter each day. That's what you want, right? You want
Yes.
it to involute. And you want it midline. Now, which is something that you would actually need intervention. Let's say, for example, the uterus is deviated, right?
Yeah.
So if the uterus is deviated either to the right or to the left, then there's something wrong. First thing we can do is what? Ask the patient to empty
Their bladder.
use the restroom, empty your bladder, right? If it is above the level of the umbilicus and it's foggy, what we can do first is
Condom massage.
Condom massage, right? If the woman is saturating more than 8 peripads a day, that means there's a lot of lochia. Also, you can do what? Condom massage. Now, take note. Other than condom massage, there are other things that you can do to actually stop the bleeding and to initiate uterine contraction. One is breastfeed. That's right. By encouraging breastfeeding, you have a lot of benefit that you're actually going to get from it to give to both the baby and the mom. You breastfeed, you're performing early bonding, right? You're preventing breast engorgement for the mom. You're also encouraging the baby to get the best nutrition and antibodies, right? And also, it helps with uterine involution. The mom feels a lot more uterine cramping when they breastfeed because it stimulates the production of the brain for oxytocin, the natural, uterine contraction hormone. So that oxytocin will be produced more the more they breastfeed. So there's a lot of benefit to that. Now, other than breastfeeding, ambulation, right? So one thing that you just have to make sure that's very tricky on ATI is that part of the thing that can happen is when you ambulate them, they might see a little bit more lochia that might come out. That's normal. But after ambulating them more and more, you will see that the lochia becomes what? Less and less. Because ambulation helps with uterine contraction. Right now, we've done everything. All of the non-pharmacological interventions, we've done it. It didn't work. The woman's, uterus is still boggy. They're still having a lot of lochia. Then that's the time that you will ask the physician for what?
Oxytocin.
Medication, right? We said the one that's on our exit is methylergotamine, right? The other name of that is metergin. We also call it oxytocin and pitocin, right? There's actually 4 different names, right? But it's actually what? The same medication. So you see either methylergotamine, metergine, pitocin, or oxytocin, they're the same thing. They're medication that is what? Vasoconstrictors, which is supposed to initiate uterine contraction to make the uterus what? Involute, contract, to actually stop the bleeding. So we did discuss that. What is something that you have to monitor again before you give it?
Blood pressure?
Blood pressure. Very good. That's the one right there. So blood pressure, right? Because methylergotamine as a vasoconstrictor can actually elevate the
Blood pressure.
So if the woman's blood pressure is elevated, you don't want to give it because that can cause big problems with severe hypertension. They can even stroke out in that situation. So to prevent that, again, monitor the blood pressure first before giving methylergotamine. Okay, now, the other thing that I also want to make sure, one of the other things that usually also comes out of the exit, Miss Brenda, how are you? Come on in, Miss Brenda. The floor is yours if you need to talk to the class. Ah, yes.
Mommy?
Miss Brenda. Just want to make sure we help out. All right, guys. So, really quick on the bundle massage, right? We were talking about. I said there's another way that this can actually be asked, and it's not just on the description of the level or the location of the uterus. They also base the question on lochia. So I want to make sure you guys are aware. Remember when we talked about lochia, that I said each lochia actually has a specific amount of days when they actually occur and when they disappear. So let's say, for example, there are 3 lochia. Lochia rubra, serosa, alba, right? So rubra, it occurs on the very first day of delivery and it lasts up to 3 days, Serosa comes up on the 4th day all the way to the 10th day. After the 10th day, the serosa changes to alba. Now, I want to make sure you guys are aware that even if the lochia disappears, but as long as it comes back on an acceptable number of days, that's fine. There's no problem for that. Let me give you an example. Okay, here's the example. The nurse is caring for a patient that is 5 hours postpartum with lochia rubra. On the 2nd day, the lochia rubra disappeared. But on the 3rd day, it came back. The question is, what should be the immediate action of the nurse?
Monitor.
Nothing. That's what I'm saying. Okay, why nothing? Because when it came back, it's still on the what?
Third
It's
day.
on the 3rd day, which is still the acceptable number of days for what? For rubra.
So what if it's on the 4th day? Then you report it?
I'm sorry.
On the 4th day? you
Correct.
report it?
If it's beyond. If it's beyond, because that means that could be what? Prolonged bleeding. Right? Okay. So as long as you don't go over beyond the acceptable number of days for each lochia, then that's okay. As long as it changes according to the actual what? Number of days that it changes from rubra to serosa. Is that clear, guys? Okay. Alright. So again, don't forget, you have to remember the number of days that the lochia is acceptable so that even though that comes up as part of the question, you will know when it's acceptable and when you actually need to report. So let's say here's an example. The patient is 2 hours postpartum. The nurse notices lochia rubra. On the second day, it disappeared, and the nurse notices that the patient starts having lochia rubra on the 5th day. What should be the immediate action of the nurse?
Report.
You want to assess, you want to report it, right? Because that could mean that there's prolonged bleeding. Because at the 5th day, it should already be what? Separated. Is that clear, guys?
Yep.
Alright, very good. Right, so in this situation, there's nothing wrong here. Looks good, right? So just document. Alright, the next one, newborn assessment. Let's take a look at this. The nurse is collecting data from a newborn who is 12 hours old. His respiration rate is 44 per minute, shallow with periods of apnea, lasting up to 5 seconds. Which of the following actions should the nurse take?
See?
So it is letter correct. Because why? That's actually normal for a newborn. Now, if you remember, the newborn's respiratory rate is usually between 30 and 60. Yeah, so being at 44 with episodes of apnea, that's normal for a newborn. And also remember, when you assess a newborn, especially their respiration, they're not chest breathers, they're more of what? Stomach. They use their stomach to really expand and push the lungs because the lungs is so small. So, in that situation, you have to take a look at their abdominal area to see, the rise and fall to determine their respiration. But apnea means period of stop. That's okay. That's acceptable for a newborn as long as the respiratory rate falls between what? 30 and 60. That's okay. Now, very quick, for a newborn, okay? Don't forget, the first thing we do when the baby comes out is suction the
Mouth.
mouth, and then suction the
Nose.
Mouth first. Right? Because that's the same way that they're gonna breathe when they come out the first time. Stomach breathers, mouth breathers. So a lot of the mucus is gonna be in their mouth, and you want to make sure you suction the mouth first to remove everything, and then suction the nose. The next priority,
Try
dry,
Try.
right? The newborn, cover up the newborn immediately with a blanket to make sure that we don't end up with body loss, body heat loss, right? You want to make sure that we can keep the thermal level of the newborn's body because they can easily get cold. That's why they're placed under a radiant heater. We don't place them near the window. We don't place them near the doors. We don't place them under the vents. We can easily lose body heat, right? So after covering it up, the next assessment is up guard, right? Okay, go to up guard. We already talked about that. We're going to newborn assessment. So up guard. Up guard is actually done twice, right? Twice. The baby comes out the first minute, and then 5 minutes. Up guard stands for a few things. What does it stand for?
Activity, pulse. Appearance, pulse, grimace, activity, respiration.
Right? So appearance, pulse, grimace, activity, respiration. It stands for those 5 things that we assess. Okay. Now, the first minute, you're not really going to get a really good up guard score. You might get like a 6 or a 7. That's okay. As long as when you do it at 5 minutes, what should you get? At least an 8. Okay? It should be at least between 8 and 9. 8 and 10. Right, when you do it on the 5th minute. But the first minute when the baby comes out, you're not gonna get a high score. Why? They're usually cyanotic, right? Especially the hands and feet. You might not get enough activity, so that will also lower the score. Because remember, the perfect APGAR score is what? 10. Right? Perfect. Perfect is 10. Right? Perfect is 10. But you won't really get a baby to get a perfect 10 because of the acrocyanosis. What does acrocyanosis mean?
Blue extremities,
Bluish,
pink
hands
in the
and feet,
middle.
right?
Yeah.
That's normal, right? No. And that's usually what will put the baby at maybe the highest is a 9 APGAR score. That's good already. That's really, really good. So we do the APGAR score, right? And then after the APGAR score, you can do further vital signs assessment, although we don't really do blood pressure check unless there's a problem with the baby. If not, it's the usual what? Pulse, respiration, and
Temperature.
temperature. Temperature, very important. How do you get a temperature from the newborn?
Armpit.
At the
Axilla.
mouth, you can do
Axilla.
axillary, right? You can do, what is this one?
Tympanic.
Tympanic. You can do temporal. Right?
Axillary.
Now, if the doctor says that it's not contraindicated, then the best way is rectal. Right? But we don't do that for newborn because of possible risk for bleeding. Right? Bleeding. Okay? So, very important. There's going to be a question on how to perform tympanic temperature check. So, through the ears. Okay? Take note. Very simple. You just have to remember this. That when you put the tympanic thermometer, that you actually rotate it towards the anterior, facing the anterior. So rotate facing anterior, the probe. Okay, so don't forget that, very important. Rotate the thermometer facing anterior. If it says facing posterior, will you pick that?
No.
Right? Rotate facing the anterior. Okay, and again, don't forget, younger than 3, back and down. Older than 3, back and
Up.
Here. Okay. Good. Alright, so here are some of the temperature that you'll need to remember. Okay, just FYI. Right, this the pulse, all you need to do is just remember that when it comes to babies inside the womb, it's 120 to 160. Newborns are usually between 110 and 160. Okay, in their pulse rate.
Oh, doing pulse. Okay.
Right? No need to remember blood pressure, that's okay. This is the one. Alright, so here we go. Please remember this.
Okay.
There are certain questions that so that you don't have to remember all of it, try to remember the ones that are up to 6 months. The ones that are up to 6 months. So everywhere from
Up to 6 months.
that's 8 to 10. So birth to 6 months, birth to 4 months, remember that. So if you take a look, sucking or rooting reflex, right? So what that means is that when you have a newborn and you actually brush their cheek or brush their lips, from birth all the way to 4 months, they have a tendency to what?
Follow the finger. Yeah.
Follow it. That's why a lot of mothers usually would take advantage of the rooting and sucking reflex to encourage the newborn to what? Breastfeed. That's one of the best ways that we can actually encourage the newborn to breastfeed, and also helps the mom to feel successful with breastfeeding. We teach them how to use the rooting or sucking reflex, which is there up to what? 4 months. So, if they ask something that is expected at 6 months, will you pick the sucking or rooting reflex? No, because it should be done by what?
4 months.
4 months. Clear? Alright. Pincer or grasp reflex. What that means, you put something in the baby's hand, what would the baby do?
Yeah, hold on to
Close
it.
the fingers, grab it. That is acceptable all the way to 8 to
10 months.
10 months. Okay, so in that situation, when the infant will pick up the object with other thumbs and
Is that
fingers,
palm?
right, then it would be only between 8 and 10 months.
Isn't pincer the? Yeah,
Oh.
palmer's the
Oh.
close.
The pincer is this one. The finger and the other thumb. See, yes, the infant pick up small objects with their thumbs and fingers. So, pick up like that. So pick it up already, 8 to 10 months. And then the palmar grasp, which is more primitive, that's the one that, yes, you put and then they close the fingers. So for palmar grasp, is this something that you'll still see at 6 months?
No.
No. It's birth to 4 months only. And then the pincer, you also don't see it much yet at 6 and 7. They only able to do the pickup using the fingers and the thumbs at 8 to 10 months. So not expected for what? 6 months. Okay, not expected for 6 months. Next one is the plantar grasp. So plantar grasp is elicited by touching the soles of the infant's foot and the infant's nose curls down. So that means you put something just like the palmar underneath the sole that will actually cause their toes to curl. That's different from Babinski's. Because Babinski is what?
You
The
stroke
toes
up.
fan out.
Yeah.
That's right. So plantar grasp, can we expect that in the 6 months? Is that normal? Yes, it's because it's birth to 8 months. So that's expected. Moro is also from birth to 6 months. Moro is start.
Yeah.
Clap, or you try to like let go of them, then they will start. Tonic neck is what we call as fencing. You know, you turn the baby's head like this. Wherever the head facing, that arm will extend. The opposite arm will curl together with the opposite leg. That's fencing. That's only good for birth up to 4 months. So you shouldn't see that at 6 months. Babinski, birth to 1 year. This is actually one of those reflexes that stays for a long time, where you actually stimulate the bottom of the foot and the tendency of the toes is to fan out. So can you see that for 6 months?
Mm-hmm.
Yes. So try to remember what are the ones that are normal or acceptable for 6 months. Okay. Is that there, guys? Very good. Okay, the next one. Also, try to remember on this one, 6 months. So, from birth, first month up to 6 months, these are the things that a baby can actually do. So 1 month, they can demonstrate head lag. Head lag is when they're, trying to get them up, but their head tends to get left behind. So you have to be. They can lift their head off the mattress and be prone. That's 2 months. So those are all expected. Raises their hand and shoulders off the mattress when prone. That's also expected. Okay. Rolls from their back to side. That's also expected. Rolls from front to back. That's also expected. And rolls from back to front. Very easy to remember here that, especially if the option says that the baby can go, you already know that that's expected for what?
4 to 6 months. Yeah.
So from the first month to the 6 months, please try to remember what the baby can do. Alright. Here's something that I want to add also though. This is a special milestone at 6 months. So what is a very special milestone? Anyone remember what's a
Double the
very
weight?
special milestone?
Weight doubles?
Oh,
This is the time that the baby is
Weight doubles?
started on
Oh, solid foods. Okay.
Very good. Okay.
Start solid.
Alright. So they're started on solid food at 6 months, although sometimes some would try at 4 or 5, but it's not very successful at 4 or 5 because at 4 or 5, they still have the tendency to have a tongue reflex. You know what that tongue reflex is, where they protrude their tongue? So they can't really eat a lot of solid food when they do that. But that actually goes away by 6 months. So meaning by 6 months, that's the best time to start the
Solid
baby
food.
on solid food. Okay, now, remember, once the baby starts in solid food, we start them off first with cereal.
Yeah.
Right? We wait for a week, and then we start them on fruits. We wait for another week, we can start them on vegetables. Okay? We wait for another week, and then you can add new things into them. It's important though that we wait each time we introduce something new by at least a week to recognize
Allergies.
Good. Because we want to make sure that we're able to recognize certain allergies that can cause a problem for the newborn. Okay, is that clear, guys? Alright, very good. So don't forget that special milestone. Any question? Alright, here's an actual example of expectation questions. A 4-month-old infant comes in for a checkup. Which statement by the parents is of greatest concern? So here is a question that, what is something that is expected of a 4-month-old? Because if she's not doing that, then that is a what? That's a big concern.
I think it's 3.
Honestly, 3.
The answer is number
3?
number 3.
Oh, yay.
Because by 4 months, they should be able to what? Follow
Visual follow.
objects with their eyes. Look at it.
Okay.
So if they're not following, that could be an indication for possible poor eyesight. That can be a big problem. Because again, at that age, they should be able to follow objects with their eyes. So they're not able to sit up yet, right? Because they need a lot of support at 4 months. Alright? This is the time, remember, that they're just starting to try to roll, right? Go. Okay? It spits up the food after feeding. That's why we can start them with. At 4 months, when do we actually start them on solid food?
6.
6, because of the what? Tongue
Reflex.
protrusion, tongue reflex, right? Does not hold the rattle as well as she did at first. Because she has to take what?
She doesn't have the grasp.
Advantage of advancing
Palmer
on her
grips.
motor reflex. So that's okay, right? Okay, so, but she should be able to follow objects. Okay. Next one. We're gonna skip this, okay. Here's the one that I want you guys to remember. This comes up. So by 10 months, it is important that the developing newborn are actually given push-pull toys. Okay? Because this is the time that they're actually able to develop their movements. Movement is a big thing here. So from their ability to roll, they start to sit up, they start to creep, they start to crawl, and now they're gonna start to what? Walk. Right? So with that advancement in their motor ability, you need to provide them something that's gonna help them be successful at that, which is what? Push-pull toys. Okay? So it is recommended that parents are able to provide push-pull toys as soon as the babies reach 10 months, because that's the time that they're going to be starting to really use their legs and start to take small steps. So here's an example of a question for expectation also. The mother of a 2-month-old asked the nurse when should start her baby on solids. How should the nurse respond?
3.
Number
3.
3. Between 4, 5, and 6, what's the best answer?
6.
6. 6 months. You don't want to do it too early because they're not going to be successful, and it's not the baby's fault. It's simply because of their reflexes. You still have primitive reflexes that will really prevent them from eating solid food. Right, so here it is. Here's just a progression of the solid food. Next, toddler, very important. One thing you just have to remember here is the progression of their ability to potty train. Right, now, don't forget, the best age for a toddler to learn potty or potty training is between 2 and 3 years old. That's the best age, between 2 and 3 years old. Potty training. That's the time that they're able to develop their ability to control when they urinate and when they have to what? Have a bowel movement. Potty training. And the more successful they are, the more likely that they're going to learn it earlier and be successful at potty training. Because here's the problem, if you start potty training them between 1 and 2, and they're not successful and they see that it's a frustration, a lot of times you will delay it more. Because they won't do it anymore because they feel like it's just giving me a hard time, I'm not successful at it, so why would I do it? So you'll end up delaying the ability of this child to potty train if you do it too early. So when is the right time? Between 2 and... So on mental health, they're going to ask you about this. They're going to ask you an example of this. They found out that there's a higher risk for regression for unsuccessful body training because of unrealistic expectation based on the age, okay, of the newborn. So that's one of the questions they ask on mental health, on how do you pinpoint or how do you describe regression? So what is regression? How do you define it?
Yeah.
Going
Backwards.
Like what do you call this? Someone who's already older but ends up doing things when they were younger, right? So let's say, for example, the child at 9 is already potty trained, but then all of a sudden the child gets sick. The child starts what? Bedwet. Urinating in bed again, or having a bowel movement in bed. So they found out that children who get sick, and in the beginning they were not successful and they were delayed on potty training, are more at risk for regression during the time that they are sick. Okay, so don't forget, what's an example of regression? Someone going back into a younger age. Another good example of regression is Alzheimer's. Alzheimer's dementia. Because that's what happens. Benjamin Button, right?
Regression.
He was born old and then started getting young. That's regression. Alright, very good. So don't forget, okay, very important about potty training and regression. Alright, this is not going to be there, but I just added this. But what's the best way to handle temper tantrum?
Ignore.
You'll be surprised. What do you think?
Ignore.
Answer.
3.
Yeah, ignore the. It's hard though in real life, right?
Children can regress when impossible.
Alright, so here's an expectation question again. This is the type of question that's going to be a lot of example. A 3-year-old child has all of the following abilities. Which one was acquired most recently? So it's 3.
Bicycle.
So that requires a lot of balance. So most likely that is the one that was just recently acquired because walking rolling a ball, stating his name, that's something that they learn, when they get to between 2 and 3 years old. Alright, very good. Next one, very important. I'm just going to tell you the highlights already to remember. 3 to 5, this is the time that they're going to start learning how to tie their shoelace. Okay, so don't forget, that's one of the very important training that we can do for fine motor movement, especially between the age of 3 to 5, tying their shoelace. Something that we need to teach them. Although it's better that we teach them between the age of 4 and 5 years old. Next thing, very important to know, that's also expected of this, they have their make-believe friends. Okay, this is the time they start seeing Peter Pan or the Boogeyman.
Imaginary.
But there's no one there. Is that a problem?
No.
No, it's not. That's normal. That's normal for this stage to have make-believe friends, alright? You don't have to send them for like a psychiatry consult, okay? That's normal. That's normal. So again, that is what? Expected, okay? Expected. Right? You need to say that they have make-believe friends. Yeah. Alright, 6 to 12, don't forget that 9-year-old, remember, they have the ability to perceive and feel the perspective of others, right? They are able to feel and know the permanence of death, but they do, in some situations, blame themselves. Okay. Also, they like to find answers at this age. So it's good to what? Explain certain situations. One more thing, one more highlight that I'm going to actually add to this that comes out also. Scoliosis. Okay.
Scoliosis.
Alright. So between the age of 10 to 12, this is the time that girls between the age of 10 to 12, this is the time that they are highest risk for scoliosis. Okay, so you probably remember, during middle school, they would usually ask for scoliosis assessment, right? Where they ask the children to bend, right? And they take a look if there is a problem with the level of their back, okay? Because girls between the age of 10 to 12 are the ones that highest risk for scoliosis. Okay, so don't forget that. They're going to ask you on an important assessment for girls. What would it be? Scoliosis. Okay. How about for boys? They're going to ask you this. Testicular carcinoma. Okay. Testicular carcinoma. Although you don't see a lot of cases of testicular carcinoma happening at 12 years old. It's more on college age. But testicular carcinoma does develop at a very young age, that it can range anywhere between 10 and 30 years old. Okay, so if the question is, for boys, what kind of assessment?
Testicular
carcinoma. How about for girls?
Scoliosis.
Scoliosis. So please do not forget that. Alright, are we clear, class?
Yes.
Alright. Alright, so here's another example of an expectation question. Encouraging children to engage in fantasy play and participate in their own care is a useful developmental approach for which pediatric age? It is number 1. 3 to 5 years. Okay, so we'll go on break first. We'll come back by 6.